Thank you, Vinay. Thank you, everybody, for being here. I'll try to move some. No conflict of interest. I'll skip the questions probably to the end if we have time, because I see it's taking too much time. So just starting off with the MDS, the point I want to make sure here, and everybody knows that MDS is a common disease, but two things. One is the most common myeloid neoplasm that we see. But what to me is important to show is actually the age that we all think that is a disease of elderly patients. But if you see the age incidence here, most of our studies, most of our clinical trials and new drugs are really focused on the smallest part of the patients. Because even if you talk about up to 70 years of age, a lot of new patients that we are diagnosed actually are beyond 70 or beyond 80 years of age. And it's a difference. So we talk a lot about new drugs, a lot of trials, but we have a lot of patients that we deal with every day that are really not fit for many of the things we do. We know that we've known for a few years that actually the MDS is a disease where mutations, gene mutations are the cause or the phenomena that we observe. And in the future of this area of research will be more and more to understand and target some of these mutations more than using chemotherapy only, as you just heard from the AML talk. Just to make some easy or easier understanding of what these mutations are, this is the frequency of the mutations seen in MDS, and they're affecting different areas of the biology of the leukemia, of the neoplastic cells. Most of the times, the mutations that we see are related to epigenetic regulators like TET2 or DNN3 alpha, IDH1 and 2, as you just held, or XCL1 and EZH2, or splicing factors. The interesting concept that actually was developed a few years ago in MDS was that there is a clonal hematopoiesis of indeterminate potential, or CHIP. And this is a concept where basically probably all of us have some meaningless mutations. But some people at some point have a clonal hematopoiesis that has nothing to do with blood counts. Patients don't have any cytopenia, any major, but these mutations are encountered. And this finding, this CHIP finding, will eventually in some of these patients develop into an MDS. The idea has been to, or the question is this clonal hematopoiesis similar to what we see as an MGUS of patients or an MBL, like a monoclonal B lymphocytopoiesis, meaning that some of the patients with this finding are supposed to, and the transformation, as we heard earlier this morning, is like the MGUS, about 1% per year of this patient will eventually transform or will become an MDS. Or some of these people with the clonal hematopoiesis can actually develop not only MDS, but also probably another lymphoid malignancy because it's a clonal hematopoiesis. So the concept is what to do with it if we happen to find these patients. And the other concept that's been introduced has been this the cytopenia of unknown significance, clonal cytopenia of unknown significance. So these patients actually do have cytopenia. They don't fit, they don't meet the criteria yet for an MDS, but they do have some clonal hematopoiesis. And these are patients actually who are supposed to become MDS patients easier than the CHIP patients. And you see here that in this review article actually was kind of trying to put some clearance to this, or ideas actually that patients with the CCUS are considered to have a low intermediate risk of developing an MDS and then eventually an AML. The concept of mutations, just the last slide on this, is actually the mutation happened in MDS even during the treatment. And there's been a paper that was showed that patients treated with decitabine or with lenalidomide develop new mutations, not only if they did transform into an AML, which is expected, but even within the same MDS pattern. So the mutation drive the transformation, and new mutation can be found over the treatment, during the treatment of these patients, like a KRAS or FLT3 mutations or WT1. There's nothing new to discuss about the prognosis, but we know that we have known for a few years that the patients with intermediate or high-risk disease have a prognosis very similar to an acute leukemia. So we talk about less than 3 years. So those are the patients that we want to identify and target with therapies, as opposed to the other patients, actually, some of the patients which have a low-risk disease, which we can observe or just transfuse or use some growth factors to support especially if they are in their elderly age. The scores are multiple. So the IPR, probably the most common is the IPSS R score, which combines the cytogenetics and blast and hematopoietic values. And we know that the high-risk patients have a very poor prognosis. In 2016, the WHO revised their classification based on morphology, identifying these categories you see here. And there's also prognostic score combining the karyotype and the WHO definition resulted in a risk stratification of patients, where also the survival is very defined by the WHO morphology combined with the cytogenetics. And again, patients at intermediate or at high risk have a very poor prognosis as well. Now, this paper that came out almost 9 years ago showed that there are some specific mutations that have an independent prognostic value. So regardless of what the patient has, if they have one of these mutations, it was shown in this paper that actually they do affect their survival. Those are the 5 mutations initially tested, the P53. And you've seen the same mutations in a AML picture. XL1, ETV6, RUNSC1, and EZH2. What happens in these patients actually is that if you have a patient which has an intermediate, a low risk score by IPSR, and he happens to have one of these 5 mutations, the prognosis of these patients will lower to the next level of the classification. So if a low-risk patient has, let's say, an XL1 mutation, the prognosis of this patient will become similar to an intermediate one. And in a similar way, a patient with an intermediate one with one of these mutations will become an intermediate 2. So basically, this is pointing to the fact that the patients who actually has one of these mutations should be considered for treatment as a higher risk patient. Treatment goes from nothing to super transplant, going through a lot of different stories. We'll talk a little bit about what the newest things are, and some of them have been known for a while. For example, there was a study published almost a couple of years ago about eltrombopag against placebo in patients with thrombocytopenia. Thrombocytopenia has been a major concern for these patients because there are not really a lot of things we can do. Over the time, they become resistant to transfusion, platelet transfusion, and they have a risk of bleeding. This actually, the eltrombopag showed a significant advantage in reducing the bleeding events in these patients. We've known now for a long time that lenalidomide is a treatment that we're talking about right now at the low-risk patients. Lenalidomide is a standard of care for patients with deletion 5, but there's also some almost 30% response in patients without a deletion 5 in low-risk patients with, for example, with cytopenia. But what has been tested recently was the 2 major drugs that we're going to talk in a minute in the high-risk patients, which are the decitabine and azacitidine. They were tested in a low-risk patient population by using a low dose for a short period of time. So decitabine was used only for 3 days at 20 milligram, and azacitidine at 75 milligram only for 3 days. And this study was done at the MD Anderson, was comparing patients actually in these 2 groups had similar mutation profile, and also characteristics. And what they found was actually that the overall response was improved with low-dose decitabine versus azacitidine. However, the event-free survival did not reach a significant difference, was 0.1, and the overall survival was similar. But overall, I think the idea is actually that some of these patients at low risk can be treated with a low dose of these hypomethylating agents. I think a big story that has been around for a long time, but only recently was published in a large study, was the use of immunosuppressive therapy in low-risk MDS patients. And this analysis was a retrospective analysis of over 200 patients treated with most of them with a ATG-based immunosuppressive therapy, some with ATG and steroids, some with ATG and cyclosporine, most of them with this regimen. And basically the analysis showed that there is an advantage, there is a treatment advantage in using immunosuppression. And you see here in different type of category of patients, in particular, but not only those who actually have a lower bone marrow blast percentage in the bone marrow, but not necessarily but not necessarily an empty bone marrow. So the concept in the past was, immunosuppressive therapy is good for aplastic anemia. For those MDS patients with a very low cellularity in the bone marrow, it will be similar. Actually, some results can be found also in patients with the highest cellularity, as long as the blasts are less, as a treatment with immunosuppressive therapy, with an overall response about 50%. What is important actually in this study to me was actually that those who did respond to the immunosuppressive therapy had a survival advantage. So it's not only a short response, they don't really relapse immediately. Those who do benefit from the immunosuppressive therapy will go to a possibly cure or long-term survival. New drugs around the block. There's been for a couple of years, for a year or so, the luspatercept and sotatercept are targeting the TGF-beta signaling in MDS because MDS patients usually have an increased SMAD2 and 3 signaling, which affects the erythropoiesis. So by blocking this pathway, there's a high increase of production of red cells and improvement in anemia. And you see here some of the results showed some good responses to this initial therapy. In high-risk patients, again, the standard of care is, as you know, decitabine, azacitidine. This has been known for several years. I think it's important to understand two different things. One is, does the molecular profile that we say is also very important in every area of treatment, does it affect the response to these drugs? Does it matter to have a mutation when you treat a patient with azacitidine, and does it prevent the response to these drugs? This study actually was published last year, showed that patients with these mutations had a similar response to azacitidine. So other than just a p53 mutation. So patient with TET2, ROX1, XL1, AZH2 had comparable responses regardless of having or not having the mutation to azacitidine. The only difference was patients with the p53 mutation who had a poor response to the azacitidine. And as expected, patients with AML versus MDS had a lower response, and patients with a secondary MDS compared to primary MDS. The combination that was attempted by SWOG of combining azacitidine with the vorinostat or lenalidomide failed. The study was published in 2017, and there was no difference in patients treated with azacitidine alone or azacitidine with lenalidomide or azacitidine and vorinostat. The only benefit seemed to happen in patients with CMML who had a higher response to azacitidine and lenalidomide compared to azacitidine alone. Now, there's another bunch of drugs that are being tested that will be the topic of the next years. I'm sure you can read very well all these things. But I just want to point to that some of the drugs actually we just heard about in the AML talk, like venetoclax or midostaurin, the FLT3 inhibitors. There are studies being done with the checkpoint inhibitors as well, and IDH inhibitors are also being tested in MDS. For example, these IDH inhibitors was published a couple of years ago in a small number of patients, but they seem to have some response in patients with MDS as well. This is a study that's been done with rigosertib, which is a PI3K inhibitor, and this actually has a very interesting and promising data that came from MD Anderson, which I hope we'll hear more in the next future. My bias, actually, that transplant cures everything, and so I think in patients who relapse or resist even MDS, but again, I want to go back to my very first slide when I showed you the age. So transplant is a curable treatment for many MDS patients, but it does apply only to a small subset of patients, although we're trying to stretch in the age now to 110, but we're going to get there. So the current algorithm in MDS, I think, is probably was published actually recently, is to patients at lower risk, depending on what their status and their profile, if a deletion 5 will be lenalidomide, if they only have anemia, erythropoietin, and then there are clinical trials or other treatment for cytopenias, including low-dose hypomethylating agents or immunosuppressive therapy. If they have high risk and they are transplant candidates, as I said before, we go to transplant. There's still discussion on whether or not azacitidine prior to transplant will benefit the outcome of transplant. This is not clear yet. There was study, there are controversial data on that. It really depends very often on the patient, on the time it takes to get to the transplant, to the overall condition. You have to balance out the comorbidities and the infection and the patient status to define what is best to go straight to transplant or wait to after some response to azacitidine. If the patient is not a transplant candidate, I think there's an open space for many clinical trials, and hypomethylating agents definitely are right now the best option we have. Should a patient over 60 be considered? Yes, I said that 105 is our age now, so for sure. But this data above 60 and 70, over 70 years of age, that still benefit from transplant. Now, transplant means many things. I think it's obviously reduced intensity regimens or mini transplant, and there are like variations of the menu in the transplant portfolio to adapt to many different patients. But the main effect, I want to make sure that the reason why the transplant is an option is because there is a graft versus MDS effect, a graft versus tumor effect, which is not really, it does not really depend on the chemotherapy that we give to prepare the transplant. Shifting to the MPNs, the award of MPNs has been clarified in the last 10 years, especially from a diagnostic standpoint, by dividing the patients in some three big groups. Those who actually have a JAK2 V16F mutation, especially in polycythemia vera, these account for over 90% or 95%. About 55-60% in essential thrombocythemia, and about 55% in myelofibrosis. And then in the more recent years, we also learned about another mutation, which is Calreticulin mutation, which is not present in patients with the JAK2 mutations. And the combination of these JAK2 or Calreticulin mutation represent the majority of patients with MPNs. A third group of patients will have an MPL mutation, especially in ET and myelofibrosis. Now, those who don't have any of these three mutations are called the triple negative patients. And triple negative sounds bad in general, and it is bad, even in MPNs. So patients with triple negative who don't have any JAK2, Calreticulin, or MPL have a worse outcome, even especially in myelofibrosis. But for example, Calreticulin mutation has shown to have a good prognostic value. Even in essential thrombocythemia, was shown a few years ago that patients with Calreticulin mutation have less thrombotic events compared to the others. To me, it's very interesting. The fact is that one of the most exciting things in the last few years has been the use of interferon, especially pegylated interferon, because it has less side effects. In my almost 30 years career of hematology, I've seen interferon being shining in different areas. I started from CML, for sure, because CML had the standard of care for patients with chronic myeloid leukemia prior to the TKI was interferon. I've seen it, again, in my experience, as a maintenance therapy in multiple myeloma patients after auto transplant, prior to the new drugs. I was actually, as a fellow, very focused on a hairy cell leukemia, which was a standard of care, interferon. And now I see him back again, shining on in different areas, which is MPNs. So patients actually, for many, many years, MPNs have not had really any treatment. The new thing was, the new breakthrough was the JAK2 inhibitors. But patients with ET or PV have been treated with hydroxyurea for probably the last 50 years and are still treated with hydroxyurea. It's cheap and it's effective. But many of these patients actually either don't respond or need a very high dose of hydroxyurea, or they cannot tolerate hydroxyurea, especially because of GI symptoms or other things. And the use of interferon has been shown in these patients to be effective. And there's been studies like the last few years, especially initially from the MD Anderson, but also the study published in 2017, that actually pegylated interferon not only improves the numbers of cells in patients with the PV or ET, but also has an effect on the tumor burden of this patient, on the allele burden in JAK2 mutated patients. As you see here in this study, it showed that about 60% of patients have an hematologic response or molecular remissions in PV and ET. More recently, a study actually was presented, I think, at ASH last year, and now is actually in press in leukemia. Was done in patients within the MPD consortium. These patients actually were resistant or intolerant to hydroxyurea and were treated with interferon. And they showed actually that these patients actually about 50, 60% of all responses, and also 20 to 30% complete responses. Myelofibrosis is actually the disease that we consider the most challenging, especially because the high-risk patients, again, using this classic standard prognostic scores like DIPS score, have a poor prognosis, like we talk about less than 2 years survival. And for these patients, again, the Calreticulin mutation has a good prognostic value, whereas the triple negative has a poor prognostic value, as you can see this in a study published by the Mayo Clinic a few years ago. XCL1 mutation is an adverse prognostic factor regardless of Calreticulin mutation. So a patient with XCL1 mutation right now and I see patients with as a second opinion, they are likely to be referred to transplant because XCL1 gives a poor prognosis. Again, these are probably can skip those. It's late. Treatment for myelofibrosis has been around for years. The new things has been the JAK inhibitors. The only one FDA approved so far is Jakafi and ruxolitinib, which we all know. It does have a good effect on splenomegaly, on symptoms, and also there was a follow-up study, showing a possible survival advantage, especially because patients were actually felt better, had less infections, less complications. The question for this is, what is next? What is beyond the JAK inhibitors? So when a patient actually is resistant or intolerant to ruxolitinib, do we have anything to do? And this actually study was published in The Lancet a couple of years ago with another JAK inhibitor, fedratinib, showing that actually indeed there's a 30-40% responses in patients who had failed or were not tolerant to JAK2 inhibitors, showing actually a patient who fails JAK ruxolitinib can still respond to another JAK inhibitor. There's another study done with momelotinib, another JAK2 inhibitor, and in this patient compared to ruxolitinib, showed a non-inferiority of this other JAK inhibitor in the arena of these diseases. And then the last study actually is with the pacritinib, in patients compared to any other therapy in myelofibrosis, including ruxolitinib. And this study showed, the study also was done within the MPD consortium. It took a few years because of some neurologic toxicity that were addressed by changing the dosing to twice a day. And pacritinib did show a positive effect compared to the standard of care, where standard of care also included ruxolitinib. So this is another agent that will be available for patients who, for example, cannot tolerate or respond to Jakafi. There's a story now a few years ago about the targeting the telomerase from Mayo Clinic, showing actually there was a regressing in JAK2 patient, the myelofibrosis, but there's some toxicity. We'll have to hear more about these studies and the last study I want to show was a study in patients with the accelerated or transformed blast cries myelofibrosis, patients who develop AML or have an accelerated phase with myelofibrosis right now are very hard to treat. Unless you can take them to transplant or do an induction chemotherapy for AML and then go to transplant, the prognosis is very poor. One study came also out from the MPD consortium where we showed in the phase 1 actually that patients who can be treated with a combination of ruxolitinib and decitabine can have some response. About 50–60% of responses, which have a duration time of 7.9 months. Now, these actually can be very beneficial, especially if the patient can go to transplant with this in this situation. They can have an overall response. Or try another treatment afterwards. So I think this is the first study in this setting with, of chemotherapy in these patients. Managing cytopenias now, the combination of drugs that you heard this morning, ruxolitinib and danazol, prednisone and lenalidomide, or the TGF-beta targeting things are being tested and are still in clinical trials. About the transplant, which is the only curative therapy for myelofibrosis, these are the first two randomized, prospective clinical trials, one in Europe and one in the United States. The data is still showing actually 70% of patients with myelofibrosis will be cured with a match-related donor transplant, and unrelated donors' results still are a little bit lower than the match data. What we know is calreticulin is also possibly a prognostic factor after transplant. There's a new study just published that showed actually in secondary myelofibrosis, secondary to polycythemia or essential thrombocythemia, calreticulin still has a prognostic value. So calreticulin is good, even in a secondary setting. And then there's a very new study that we just published within the MPD consortium of over 100 transplants where they were analyzed for the prognostic values of mutations that they had at the time of diagnosis. You see these are the same mutations that we have seen until now in MPN, in AML. And what was actually surprising, actually the mutation that turned out to be have a prognostic value after transplant were not the calreticulin, were not the JAK2, or not the XL1, but were actually only these two, U2F1 and the NM3 alpha, which turn out to have, as you see in these survival curves, an independent advantage survival in those patients who actually did not have these mutations. The last thing I want just to show as a message for the non-transplant people, transplant is feasible for patients now with the haploidentical donors. Haploidentical means actually the patients who don't have a matched sibling in the family will have a lot of possibilities within siblings and parents and cousins and grandparents of only haplotype matching. In myelofibrosis, a study now has been done. This is one of them. Actually, haplotransplant has similar results than matched sibling transplant with this regimen that was published actually a couple of years ago. I think the questions probably are too late for the questions.
I think we can do it.
We can do them? Yeah. Okay. So, based on what I told you in Russian a little bit, is it a molecular diagnostic information relevant to the treatment of patients with MDS? No, only important for research purposes. Yes, but only if multiple mutations are detected. Yes, there are specific mutations with independent prognostic value. Yes, but only when transformed in ML. Thank you very much. That's great. I change before you change your mind. Immunosuppressive therapy achieves an overall response in approximately 50% of low intermediate 1 patients. It is important to note that no. I think the response would be B. Patients who respond have a significant survival advantage. The 5% was actually, thank you, the 5% was actually the blast cellularity, the blast number, the blast in the bone marrow, not the really the cellularity. And the last question, I think, is a patient with myelofibrosis often improve their symptoms on JAK inhibitor, ruxolitinib. If they fail to respond or cannot tolerate, they will not respond to another JAK inhibitor. Outcome of transplant depends on response to ruxolitinib. Transplant has better outcome in JAK2 patients. Mutation of DNM3 alpha correlates with post-transplant survival. No, but it's okay. The answer is D. Yes, thank you. I think that's it. Thank you very much.